Good afternoon, dear committee, dear audience. I'm very honored to present in front of you my PhD thesis titled New Insights into Pharmacology Under Special Clinical and Environmental Conditions. Just a few words about me. My name is Amir Makole. I'm a pharmacist and a PhD student here. This is our research team, and our vision is to enhance drug effectiveness in special clinical situations. While to achieve this, the mission is to conduct innovative research to optimize drug utilization in all patients. Now, have you ever wondered what happens with the space pharmacology when the patients are exposed to such special conditions? For example, space flight or spinal cord injury, or even polypharmacy in certain diseases? Well, we did, and that's why we have these exact 4 specific goals, out of which the first one is the space flight and microgravity models change pharmacokinetics and pharmacodynamics, and it's a systematic review and meta-analysis. Why exactly this one? Well, because the use of medicines in space travel is steadily increasing. And while we tend to take longer journeys, they carry a higher risk of diseases, and therefore we need more drugs on board. Additionally, we already know that microgravity induces such physiological changes that could have an impact on the pharmacokinetics and pharmacodynamics, resulting in a reduced effectiveness or intoxication, and this could pose a threat to the lives of the crew. That's why our aim is to understand the effect of microgravity on pharmacokinetics and pharmacodynamics, and therefore we can suggest necessary interventions accordingly. To achieve our aim, we asked this clinical question where we wanted to compare pharmacokinetic and pharmacodynamic parameters between healthy humans exposed to space traveling and/or microgravity models and normal Earth gravity. We hypothesize that drugs under the effect of microgravity will experience changes in the ADME profile and pharmacodynamics and potentially lead to either inefficacy or intoxication. We did a systematic search in 5 major databases, and we could include 29 eligible full texts. Before jumping to results, let's briefly discuss some important aspects. The major outcomes that we assessed are Cmax, which is the highest concentration of a drug in our bloodstream, measured in micro or nanograms per milliliter. Tmax, which is the time necessary to achieve this maximum concentration, and half-life, which is the time needed to decrease maximum concentration halfway in our bloodstream, both of these measured in hours. And lastly, AUC, or area under the curve, is the overall drug exposure measured in micrograms or nanograms times hours per milliliter. And based on the duration of the exposure, we have categorized it to short-term and long-term. By short-term, we mean 1 to 3 days of exposure to those called microgravity models, which are analog models here in Earth simulating microgravity conditions, also known as head-down tilt bed rest models. And in the long term, we mean more than 30 days of exposure, and in these types, it's actually a real spaceflight exposure. Now let's see some results. Here we have the Cmax and AUC of several drugs pooled together in short-term duration exposure to microgravity models. And even though we cannot see any pattern of changes in these data, the impact of microgravity is clear. For example, here, if we take AUC, you can see that AUC varies from minus 26.77 for ketorolac to plus 25 for verapamil. Also, we could do a single drug meta-analysis for acetaminophen, for only acetaminophen in this case. And here we can see the Cmax and Tmax in short-term exposure, where Cmax is increased while Tmax is decreased in microgravity models. While in long-term exposure, we can see that Cmax is decreased and Tmax is increased in spaceflight environment. In summary, we can see opposing trends between the short-term duration to microgravity models and long-term to spaceflight, where in microgravity models we can see an increasement of Cmax while it was decreased in spaceflight studies. And again, the opposite trends was seen for the Tmax too. This could be explained by 2 factors. Firstly, these microgravity models probably are not replicating in the best way the space environment for pharmacological studies. And secondly is that time or the duration of exposure to microgravity should really be taken under consideration, because in the spaceflight studies, we're talking about 30 or more days of exposure, and actually in these studies is hundreds of days. While from the confidence intervals, we can see that these results are actually not statistically significant, but we believe that these results are clinically relevant because even though acetaminophen is considered somewhat a safe drug, according to Tamargo et al., if changes like this happen to drugs with a narrow therapeutic index in the amount of drug in blood, it can easily slip under effective amount or above the toxic amount of the drug. Of course, our research has strengths and limitations. Among strengths, this is the first systematic review and meta-analysis done on the field. We managed to include only studies of interventions and also studies that involved spaceflight, and the risk of bias was predominantly low. But we were limited by the high heterogeneity and low sample size. There was limited spaceflight data available, and due to that, scientists actually had to use microgravity analog models in Earth. In conclusion, microgravity affects the kinetics and dynamics, but there's high heterogeneity in the available data, and no clear patterns could be identified across drugs. Also, the currently existing microgravity models likely do not replicate the space environment appropriately for pharmacological studies. Therefore, for practice, we imply higher caution when dosing drugs, especially those with narrow therapeutic index, to astronauts, and dosing recommendations for potential space travelers should be included in the SMPC, while for the research, we imply further research to clarify the exact effect of microgravity on pharmacology, and also further exploration of the duration of exposure to microgravity. Additionally, a new microgravity model for pharmacological studies is needed. This manuscript is submitted in Nature Communications and right now is under peer review. The second study is kind of totally the same with the first one, but here we're focusing on animal models, where, for example, in the right one, you can see real animals that went to space, or in the left, there are microgravity analog models in Earth, for example, this one, which is called tail-suspended rat model. We had a similar question in a similar PICO framework, and right now we're doing the title abstract selection phase. And the third project is investigating the pharmacokinetic drug-drug interactions and risk of bleeding in concomitant use of antiarrhythmics and anticoagulants. Why exactly this one? Well, because the atrial fibrillation is one of the most common heart rhythm disorders. Within 1 year after diagnosis, 1 out of 6 patients die from it, and within 5 years, 2 out of 5 patients die. According to the newest guideline, direct oral anticoagulants and amiodarone, especially for those with heart failure with reduced ejection fraction, are recommended with high level of evidence to be used. But there's the problem. Both of them have an impact on the liver enzymes and proteins. For example, direct oral anticoagulants are actually substrates of CYP3A4 and P-glycoproteins, but amiodarone inhibits them. So here we have a pharmacokinetic drug-drug interaction. Also recently, several studies published significantly increased risk of bleeding in patients that take these two together. So now we have a question of a risk-benefit. Are we actually harming patients while we're trying to protect them? So our aim is to understand the association between concomitant use of antiarrhythmics and direct oral anticoagulants in one way, and pharmacokinetic interactions and bleeding risk in the other hand. To do this, we ask this clinical question, and we want to compare atrial fibrillation patients who take direct oral anticoagulants together with class 3 and 4 antiarrhythmics, compared to those who take only direct oral anticoagulants or with other classes. And we want to assess clinical and pharmacokinetic outcomes. We hypothesize that concomitant use of amiodarone and direct oral anticoagulants changes the pharmacokinetic parameters and increases bleeding risk. And if our hypothesis is true, then we could update guidelines for higher caution when co-prescribing these drugs, or even totally contraindicate using these drugs together. We plan to use this search key, and right now we're on the Prospero protocol drafting phase. In summary, we have 4 ongoing projects. Well, the first one is actually submitted. The rest 3 ones are planned to be submitted until the end of next year. And in terms of additional activities, I was honored to be involved in the Center for Translational Medicine as a scientific methodology supervisor for 10 PhD students and meta-analysis deputy coordinator. I took teaching activities in the Department of Pharmacology and Pharmacotherapy and attended various local and international conferences. I would like to conclude my presentation with my favorite quote: "The most exciting phrase to hear in science, the one that heralds the most discoveries, is not Eureka, but that's funny." So please don't stop asking questions, even if they seem funny, silly, or unrealistic, because they lead to the biggest discoveries. Thank you very much for your kind attention.
Thank you very much for this special presentation. Let me ask the first question. What do we know? What you know about in space flight? Which organs, the function of which organs can change? Do you know?
Well, there are many physiological changes that happen while space traveling. I can mention, for example, due to blood redistribution that happens due to microgravity, the function of kidneys and then heart changes. Also, psychological things, for example, sleeping and isolation. All of these are factors that impact the astronauts. Musculoskeletal system is highly impacted because there's a decrease in the muscle mass, especially if as long as you stay in the space, there's higher decrease in the muscle mass. That's why astronauts, when they come back from like a longer journey, they can't even walk for a period of time, etc. So yeah.
Okay, thank you. So soon, I think in clinical trials, this space flight things should be also implemented. Is there any question?
Thank you for your presentation. I would like to ask about the first project. Would you expect similar results with animal models?
That's a good question. Thank you. Yeah, we kind of expect similar results to appear in the animal models, but mostly in the animal models we expect to confirm what we found from humans in one hand, and in the other hand probably because as you saw there was high heterogeneity in the human data, so maybe animal data could help us design like a study or have a more specific study design to see the exact effect of microgravity. Thank you.
You suggested better models for microgravity are needed. What the heads-down bed, long-term bed experiment allows is the distribution to the head, to the brain, which is a major problem in space. What would these models have to look like? I know Thomas Reiter, one of the astronauts on the space stations personally, and discuss these issues with him. Most what they do is non-animal models, but cellular models. Can you foresee a cellular or organoid model that could help you decide this question, pharmacokinetics, dynamics in space? Or what would the models on Earth have to look like if you want to test something in humans that you later want to bring to the International Space Station?
Well, about the organoid I think in vitro models for microgravity, I think they would be quite useful, and they are actually in use as far as I know for example, space cell culture modeling and
for
and
immunology they use them, but I've never heard them using them for pharmacokinetics or dynamics.
That's what I'm not sure. I didn't at least from my what I looked until now, I didn't find research published on pharmacokinetics and in vitro models, but I think they would be useful. While for human modeling, that's yeah, a really good question. I mean, for the models that we have now, they focus mainly on the blood redistribution that happens to the head due to the head down tilt position, and but there are a lot of other factors which happens in space, and we actually cannot take maybe under consideration here in Earth when we want to apply a model. So I honestly don't know what would be a better model, but what I do know is that according to the data, these models are not appropriately mimicking the space environment. So I don't know, a new one, yes, but what new one, that's what I don't know yet.
Thank you very much, Amir.
So I just congratulations to your presentation. What are the usual methods to examine pharmacokinetics and pharmacodynamics? And is there any difficulties or limitations in space to conduct these examinations?
Well, what I could say for pharmacokinetics, the only limitation, and it's actually kind of a big one, is that in spaceflight it's kind of hard to take blood samples, and that's why they have to do these measurements on saliva samples, and that's the only way, at least from what I read, one of the only ways to do this measurement. And you know, saliva samples can be highly confounded by other factors as well. While for the pharmacodynamic parameters, those that are reported, at least from the spaceflight studies, are not actually like really measurements like the effect on receptors or whatever else. It's just the activity. So for example, if it's an antihypertensive, they measure the blood pressure and see its effect. So that's the only, let's say, kind of pharmacodynamic effect that could be measured and reported from spaceflight data.
So regarding this last question, so if they're not taking any blood, that for instance, when investigating a different type of drugs, then you're not really able to give answer to if it's like, for instance, raising the liver enzymes or not. Because from the saliva, you're not able to give this, right?
As far as I know, no. And I didn't see any, because seeing the liver enzymes would be maybe actually helpful because we could define the metabolism of the drugs, but they weren't reported in any of the studies, and surprisingly not even in the Earth models as well.
Thank you.
Congratulations on your presentation. I was wondering, I saw that you had different type of drugs pulled together in one of your forest plots. Are they similar in their pharmacokinetics and pharmacodynamics profiles?
No. Unfortunately not. One of the reasons why we could do a single drug meta-analysis only in the acetaminophen is because it was the only drug that had enough data to be pooled in a meta-analysis. The other ones, we had to pool all of them together just to kind of see if we can see a trend of changes. We tried to see if it's due to the pharmacokinetic models, if it's due to the structure of the drugs, if it's due to the mechanism of action, but none of them actually made sense to do subgrouping because it was quite heterogeneous in all of them. So that's why we only kept it to pool together for all of them, just to see that there's actually a clear impact. But why and how, that's still to be investigated.
Thank you.
Thank you. My question is not about space, but about the atrial fibrillation part. According to the guidelines, is this risk you described recognized or not yet?
That's a very good question. It's surprisingly, it is mentioned in the guidelines somehow. Okay. So you know the guidelines are like thousands of pages documents, right. And then if you go through the text, you will see that, because we all know that amiodarone is not the perfect safe drug that we would like to use, and it of course gives you like precautions about possible interactions and side effects, but that's all. And actually, I can show you from the guideline here that amiodarone is recommended with 1A for these patients, and also oral anticoagulants are recommended with 1A evidence. And if you see this, actually amiodarone is not mentioned anywhere for these direct oral anticoagulants except from dabigatran to like reduce the dose of the anticoagulant or increase or reduce the dose of the antiarrhythmic. So even though they kind of acknowledge the risk from the retrospective studies already existing, there is no recommendation for all. So for example, you can see for warfarin, it says reduce warfarin dose if you use amiodarone, but you can freely co-prescribe apixaban, edoxaban, and rivaroxaban with amiodarone, and it's not actually even mentioned here that like be careful.
Okay, so not yet. Thank you.
Thank you.
Okay.
You know, in the routine practice, there is a very strict recommendation regarding the DOAC therapy and to prevent the GI tract bleeding. So usually we recommend PPI, proton pump inhibitor treatment to prevent the GI tract bleeding side effects of DOAC therapy. Do you have any information about the pharmacokinetics, pharmacodynamics of PPI in the space?
In space,
or in gravity?
actually, no, not really, and I haven't seen any publication which included PPIs.
But your second project was examined in gravity.
The second was
I mean
yeah,
the
in animal
DOAC
models.
and
The third one, the DOAC,
third
but
one.
it's not in microgravity. It's like for atrial fibrillation patients who are taking both of these drugs, so concomitantly amiodarone and direct oral anticoagulants.
I see.
Because I've seen several publications which reported increased risk for bleeding, all like major bleeding, gastrointestinal bleeding, major bleeding, all bleeding, etc. And that's why I saw it kind of necessary to systematically review the literature and maybe come up with some recommendations in this field.
Okay, thank you.
Thanks.
Okay, thank you. Thank you for the nice presentation. I just wanted to ask why only class 3 and class 4 anti-arrhythmic?
Yeah, so when I tried to design this study, I was thinking of what should I include only amiodarone, or also because I wanted also to see what is happening with other drugs and if we actually have other drugs reported. But why I chose only class 3 and class 4 is because the class 1 antiarrhythmics are not like the most commonly prescribed, and even when they are not related usually to patients who have structural or heart diseases or patients who